Hello, Leonard.
Hello and good morning, everyone. I have the great pleasure, I'm Len Katz. I'm the chair of the Medical Emeritus Faculty Society, and we are very proud to continue our tradition of having roundtable presentations and luncheons. I don't want to call it a lunch because we're not having lunch. But even with Zoom, we can continue with this very important function of ours. So we're proud of that. Thank you to the Emeritus Medical faculty who are here and to all who are joining us today. We welcome you sincerely and we look forward to your input. There will be multiple presentations followed by questions, so please stay tuned to that. Today's topic is, in my mind, a very important, almost critical topic as we see transition going on in healthcare. We are going from what has been a very individualistic profession of medicine going back historically to group practice, and now the next major step is team practice, working together with various interdisciplinary functions, working together for the care of individual patients and for our entire society. I had a recent experience. My brother was in hospice and he experienced team care of the highest sort, both when he was in his home and when he was inpatient. There were physicians, there was a palliative care physician, a personal nurse, social worker, nursing aides, support people of all sorts, and he received superb care that could not have been provided by any single individual. This required a real functioning team, and I'm very impressed with it, and we need it as we go forward. So we're very pleased today that Dr. Michael Noe, who's had his own real experience with team practice, that he is going to be moderating the discussion for today. So I'm pleased to turn it over to Michael. So please take on, and Jennifer and Tracy. And before we do that, I'll keep speaking just for one moment. I want to say that this possibility that we're seeing today of this kind of presentation would not be possible without the marvelous help that you had from multiple people, two in particular, Tracy Owen and Jennifer Britton, and we want to thank you. So thank you for your help in making this possible. And at that point, I turn it over to Mike.
Thank you, Len. It's my pleasure to welcome everyone and also to provide our speaker introductions. First, a few housekeeping items. Today's session will be recorded and we will share the link following the meeting. Also, please make sure that you are muted when others are speaking, and we will plan on taking questions at the end following our final presenter. And that can be done either verbally or through the chat room. I'm thrilled to welcome and introduce our panelists today. Each will share more about their role and how it contributes to the interprofessional model. And they will discuss how training is going amidst the pandemic, as well as share plans for the future. In fact, last week, this group hosted a very successful IPE Zoom with over 900 participants from all the health sciences schools, and we look forward to hearing about that program as well. I want to share a personal reflection with you before I make the introductions. My personal experience with interprofessional education actually dates back over 50 years. When I had an elective experience as a senior medical student and then a would-be radiologist in an inner city clinic staffed by a physician, a nurse, a social worker, and a psychologist. In this clinically and professionally intimate setting, I developed a true appreciation of the value of team-based care, and actually, as a result of that, set off on a new career path in internal medicine and preventive medicine. Many years later, I appreciated the wisdom of the World Health Organization in encouraging interprofessional education experiences in all of the health sciences. And as we implemented it here at UB, I again saw it as a potential game changer, encouraging more collaboration and improved communication among members of the health professions. So I am sure that all of our students, although it may be to a different degree, will enjoy the benefits of the experiences they're having in this new educational model. We will lead today's discussion with Dr. Lisa Jane Jacobson, who will provide insight on how medical students are being trained to work within a healthcare team. Dr. Jacobson is the Associate Dean for Medical Curriculum in the Office of Medical Curriculum at the Jacobs School. She is involved in shaping the medical curriculum, revising course content, assisting the course directors and faculty, and overseeing the development of a new medical curriculum. Following Dr. Jacobson, we will hear from Dr. Patricia Otake, who will provide the training model for students in the health sciences schools, including management, and how she is preparing them to work within a team model. Dr. Otake is Assistant Vice President for Interprofessional Education and Associate Professor of Physical Therapy at the University at Buffalo School of Public Health and Health Professions. Dr. Otake brings over 10 years of IPE experience to her UB IPE program leadership role. We congratulate Dr. Otake on the UB IPE program, which received national recognition as an IPE program of merit by the Association of Schools Advancing Health Professions in 2019. Last but not least, Dr. Jessica Kruger will provide insight on working with the interprofessional team of health professionals and medicine. She will share examples within her advisor role and experiences observing students involved in team models such as at the Lighthouse Clinic. Dr. Kruger is Clinical Assistant Professor of Community Health and Health Behavior for the School of Public Health and Health Professions, and an expert on health behavior decision-making and the public health impacts of addictive behaviors. With that, I welcome Dr. Jacobson for her presentation.
Thank you so much. And thank you very much for inviting us to this, to participate today. And also, I'm just so pleased to be here with my good friends and colleagues, Dr. Otake and Dr. Kruger, who I get to work with on a regular basis. They're exceptional professionals and educators. So let me share my screen and we'll talk a little bit about what we mean when we talk about interprofessional collaborative practice. I hope everybody can see that okay. Jennifer, is that okay?
Yes.
Okay, wonderful. As Dr. Noe had mentioned, I work as a curriculum dean, but I'm also an obstetrician and a gynecologist. And I have been working for actually probably almost 30 years as a clinician. And I've been working in many healthcare settings over these years, in the operating room, in the delivery room, labor and delivery, resident clinics, private practice offices. And one thing I've come to fully understand with great certainty is that the best care of patients is delivered by a well-coordinated team of healthcare professionals. I'm just going to touch a little bit about going over some examples of team-based healthcare delivery. Also talk about what we mean when we say interprofessional collaborative practice, and why it's so important for promoting safe and efficient healthcare. And then talk about what interprofessional education is, and why we believe medical students, it's an important component of their education. This is my mom. My mom is my very first influence when it comes to interprofessional collaboration. She was a nurse and a nursing educator, and really taught me the value of healthcare professionals working together, contributing their own expertise in the care of the patient. If you would just take one moment to ponder and think back to a time where you personally might have had a medical situation or a complex problem, medical problem that you are undergoing yourself, or maybe a friend or a loved one, and somehow you're involved in that, in helping them with that experience. And if you think back about it, you probably would imagine there were a variety of healthcare professionals involved in that experience, in that treatment. It may have felt like there were many details to keep track of, many moving parts, and at times it might have been feeling overwhelming, which is what a lot of our patients feel. It has been said that how care is delivered is as important as what care is delivered. And we all want healthcare professionals who are involved in our care, who are, working in a coordinated fashion, collaborating to design our optimal treatment plan. We want them to be organizing our healthcare visits and labs and imaging and therapies in a way that fits into our schedules in an efficient and expedient way. We want our healthcare team to remain in close contact, sharing important information with each other and adapting management plans as the needs arise. We want them communicating with us so that we're able to be aware of the changes and the next steps in the plan. This would hopefully lead to faster, more efficient care that would cut out redundancy and unnecessary testing and costs and eliminate waste. This kind of coordination would improve safety because there'd be fewer opportunities for mistakes or things falling through the cracks or information being missed. And this kind of care would be comprehensive and holistic. And the team that would be working to coordinate this would kind of have our overall well-being in mind as we navigate through this complex system of treatment. That kind of a system sounds pretty idyllic to me. And in order to reach that goal, we really do have to have what we call interprofessional collaborative practice as part of that. That's when multiple healthcare workers from different professional backgrounds work together with families, patients, carers, and communities to deliver the highest quality of care. I know most of you are practitioners of some sort, a lot of physicians here in this group. I believe we might have invited some nurses. I don't know if they were able to attend, some emeritus nurses. But a lot of you have seen situations, right, in acute care settings where you really had to have a well-orchestrated team working very quickly together, in concert in order to be able to do some life-saving therapies. And you've also probably seen many occasions where, there's more longitudinal care that needed to be coordinated amongst healthcare teams so that somebody could get their rehabilitation done and get back on their feet and back to their normal living, or people who are, working with their chronic conditions and require lots of care of many, many different team members over time. Well, as an OBGYN, I have been treating pregnant women for years. And what I've seen and fully appreciate is that it honestly takes an entire team to take care of a pregnant woman. I think about from the moment a pregnant patient walks into my office, they're greeted by a professional who's sitting at the desk, and she might be, helping to take some important information from the patient, help them schedule their appointments, help them figure out their insurance and how they're going to be paying for, this care that they're going to receive. They might then be seen by a medical assistant who will be taking some information from them, asking them how we can be of help on that day, and maybe inputting information into the electronic health record and sharing this information with the provider. You might have a physician then who's going to kind of assess this patient and make a diagnostic plan and make a plan of management. And that physician may decide, I think I need to consult a few of my health professional colleagues to make sure that this management plan is appropriate. It's going to be in the best one for the patient. Some of our patients that I care for require, help from social services. Sometimes they need help getting WIC, women infant, programs so that they can have the proper nutrition in their households. Maybe they need transportation help. Maybe they need help figuring out how they're going to be able to, financially pay for their care as well. And our social workers in our clinics are extremely helpful with these problems. A lot of our patients, unfortunately, get gestational diabetes. It's not an unusual problem, especially here in Buffalo. And when our patients get, have this problem, we often have to involve our nurses who are going to be teaching them how to do their glucose monitoring and, use the glucometer and inject insulin. And then we get a pharmacist involved, right? Our pharmacist is going to have to supply this kind of medications. And then, of course, a dietitian is important in order to try to get them to incorporate the proper, eating and habits in to try to combat the diabetes. A lot of our patients need counseling. We often will find we have to refer people out for help with getting through numerous stresses or depressions or anxiety. We often turn to our psychiatry or psychology or social work colleagues for that. Physical therapy. Our patients have sciatica and low back pain and other injuries or stresses and strains from carrying the pregnant uterus around. And so we send a lot of our patients to physical therapy for work on that. And then, of course, the dentist. You can't forget the dentist. Very important part of care that our patients need to have preventative dental care even when pregnant, and often, just as anyone else would, we might have a dental emergency. So this team is utilized regularly in just the care of individual patients. In the delivery room, we have physicians, we have scrub nurses, we have circulating nurses, all helping. Behind the drape, we often have we have anesthetists and nurse anesthetists who help as well. And then, gosh, here's a delivery of twins. So you have two units here set up to deliver twins or to receive a newborn twin. And you might have respiratory therapists, you have neonatal intensive care unit nurses. You can imagine with all of these people, if you don't have a coordinated team working together, you're not going to get the outcomes that you need. So, 21st century healthcare is so darn complex. And it really requires interprofessional collaborative practice. We have more chronic disease than in the past, and we have to manage all of that. Our patients, our population is older, right? And so, older patients may have more illnesses that have to be managed. We have lots of technology now, tons of technology everywhere, including our Zoom here today. And we're working in a fast-paced environment, always. And there's so much new medical knowledge just exploding. And it is absolutely too much for one provider to think they're going to be able to know it all. And it takes a team, each taking their own portion of expertise to contribute to the team. So, we believe that interprofessional collaborative practice is really essential for 21st century healthcare. These healthcare teams have to work safely and efficiently together to produce the best outcome for our patients. And as we all know, we're working on improving our healthcare quality and safety. There is an unacceptable rate of medical errors that occur every day. And how do we reduce those errors? While improving communication amongst providers is one of those ways. That will help to reduce mistakes. We need team input for treatment plans that allows a varied experience of all of the team members. And again, communication will allow us for coordinated services for the patients, which again, improves quality and safety. We also have a significant problem with healthcare costs in our country. And by doing interprofessional collaborative care, we can avoid duplication of services by many different providers when they're not necessary. And we can provide much more efficient care using team-based models and deliver, care that maximizes health and will hopefully avoid costly illnesses. So in addition, providers are happier working in these environments. Well, it's been shown that in teams, the provider gets a lot of satisfaction that way, and the patients feel, that happier as well. So we do believe that in order to get to that goal of interprofessional collaborative practice, we have to include interprofessional education in the training of our students. So, what is that officially? IPE, or interprofessional education, is defined as when two or more health professionals come together to learn from, with, and about each other in order to improve collaboration and patient care. So we develop experiences where our students can learn from, with, and about each other. In the past, our training had been very siloed, right? Every profession had its own school, and you barely ever got to see any other profession while you were training. And our students had minimal exposures to the roles and responsibilities of other health professionals. And we never spent a lot of time teaching about teamwork. So we changed that up. All right, we've developed all kinds of new experiences for our students, and Dr. Otaki will talk about what we are doing here for all of our health profession students. But now this is a picture from one of our interprofessional education experiences, our IP forum. And in our interprofessional education at UB teaches our students that it's really important to have a respect and understanding of the roles of other healthcare professionals, and that we want them to understand the interdependence across professions. We also want to emphasize communication and collaboration within interprofessional teams, and our goal is to break down these silos. And eventually, what we really want for the future and future of healthcare is to not only have better outcomes for our patients, we also want to make sure we're lowering costs as well. We want to improve our patient experience, and we want them to be satisfied and happy with the care that was delivered to them. And then in the process, we believe that you'll have an improved clinician experience as well. So thank you for listening, and I'm going to now pass the baton on to Dr. Otaki, who's going to tell you about our educational programming.
Good morning, and thank you, Dr. Jacobson, for such a terrific way to lay the groundwork for interprofessional collaborative practice and its importance. And thank you, Dr. Katz and Dr. Noe, for inviting me and for the lovely introduction. So what I'd like to do in about the next 15 minutes is to tell you about our interprofessional education program here at UB. And so to start off, I'm not getting my slides. There we go. Health professions education, as Dr. Jacobson said, has traditionally been provided in silos. And so academic health centers are very good at training excellent physicians. And health professions education's programs develop these excellent healthcare providers, but still they're in silos. And I'm sure now you can appreciate that that's not, from Dr. Jacobson's presentation, that's not necessarily the optimal education model any longer. And so this change, I mean, it was beautiful that Dr. Noe shared his experience from a while back. And in 2000, I'm sure some of you remember the Institute of Medicine report that was published called Crossing the Quality Chasm, a new health system for the 21st century. And in this report, the authors stated that highly valued healthcare cannot be achieved through the uncoordinated actions of individual physicians and other healthcare providers, but that they need to learn to work together. And so, as Dr. Jacobson again pointed out, we need to change the way we're educating our students. So around the same time that the IOM report came out, the Institute for Healthcare Improvement was formed, and they published the triple aim that summarized the goals to improve the goals of healthcare, which were to improve patient experience, including outcomes and satisfaction, improve population health, and reduce the per capita cost of healthcare. And then again, as Dr. Jacobson outlined, recently the quadruple aim has been proposed, and this additional aim recognizes the need for healthcare team well-being or improved staff experience, since burnout is occurring at alarming rates. And so with this quadruple aim of having the improved staff experience, it's been very important to move interprofessional education forward. And so research has shown that when healthcare providers work together, the quadruple aim can be achieved, and Dr. Jacobson alluded to that. So interprofessional collaborative practice improves safety, patient outcomes, patient satisfactions. Patients are just happier when they perceive, not even actually receive, but perceive that their care is being provided by a team. And it also, team-based care also improves population health. It's known to strengthen health systems. Great examples of this are in the area of diabetes care and community-based mental health. Collaborative practice has evidence to reduce the per capita cost of healthcare. And importantly, when providers practice in teams, burnout is reduced. People are just happier when they work in teams. So interprofessional collaborative practice meets the quadruple aim. So to illustrate the value, again, sort of in our health systems of teamwork and collaboration by health systems, here's an example from the Cleveland Clinic, who identified clinic leader behaviors. And they feel that by demonstrating these 4 clinic leader behaviors, that the Cleveland Clinic leaders live the mission, vision, and values of their organization. And I want to point out that one of their 4 behaviors is fostering teamwork. And additionally, the core values of Kaiser Permanente, which is one of the top healthcare systems in the country, also emphasizes physician leadership, collaboration, clinical teamwork, and keeping people well. So by considering these values of the Cleveland Clinic and Kaiser Permanente and many other healthcare systems, physicians have to be ready to function as part of or even to lead an interprofessional team of healthcare providers. And so how do we get there? So in 2011, the Interprofessional Education Collaborative published their core competencies for interprofessional collaborative practice, and the AAMC was part of this initial initiative. And those 4 core competencies are values and ethics, roles and responsibilities, which covers who's on the team and what do they do, interprofessional communication, so that all of the different professions can drop their jargon and communicate clearly with each other, and as well as teams and teamwork. So ensuring that our healthcare workforce knows how to work effectively on a team. And so our program here at UB involves health profession students from 12 health professions education programs, and we follow the IPEC core competencies and have a patient and community level focus in all of our programming. And we have packaged our interprofessional education program as a micro-credential program. So I want to tell you a little bit about micro-credential programs. In 2018, UB introduced micro-credential programs, and we saw this as the IPE leadership team here at UB saw this as an opportunity to really give our students an opportunity to really showcase their IPE skills. And so a micro-credential program is a small program, so it's smaller than a certificate, that allows students to gain relevant skills, and skills is the optimal word here, that are needed in today's workforce. And micro-credential programs are often a collection of digital badges. And so what's a digital badge? A digital badge is, again, a new credential that allows students to showcase their specific skills that they have gained through learning experiences. So when the student is issued a digital badge, they're issued a clickable icon, and they can share that. And when you click on the icon, when the icon's clicked on, it opens up web-based information that shows the issuing institution, so that UB issued this digital badge, the date it was earned, the criteria that was required to earn the digital badge, and also the evidence for that specific student that shows that they have met the requirements for the digital badge. And so the students use these digital badges to showcase, again, these skills, knowledge, and achievements. And it has more ways to showcase this than a typical transcript. So digital badges can be shared on social media accounts like LinkedIn, and LinkedIn is very heavily used for recruitment these days. They can use it on digital resumes, so in residency applications, in their e-portfolios, and even some students stick them in their email signatures. So it really is a way to showcase this knowledge and skills that they have. And so our UB micro-credential program is called the Interprofessional Collaborative Practice Micro-Credential Program, and it consists of 3 digital badges, and they're in a scaffolded type curriculum. And so our first badge, offered at what we call an exposure level, is called Interprofessional Collaborative Practice Foundations, and this consists of 3 learning experiences. The students learn about the IPEC core competencies for interprofessional collaborative practice by engaging in our Foundations of Interprofessional Collaborative Practice online learning modules that are hosted through a UB Learns course. And once they have this foundational information, they are ready to engage with students from other professions. And so they participate in a fall forum and in a spring forum. And as Dr. Noe said, last Thursday, we had 900 students from 12 different health professions in 8 schools come together in small 7 or 8 member faculty facilitated groups to discuss problems related to a case of an individual who had opioid use disorder. And again, the discussion among the students was to learn about each other, to learn how they can work together to collaborate, and to really look at opioid use disorder at both a patient level and the population and systems level. We have another interprofessional forum in the spring that follows a similar format that focuses on an individual with chronic physical and mental health conditions, which is not unusual for our patients. So it really gives these student teams an opportunity to really start forming collaborative conversations and associations. Our second digital badge then allows these students to take this knowledge that they've learned at the foundations level and really bring it to the next level. So in the communication and teamwork digital badge, the students work in contextually relevant teams, doing contextually relevant things for their profession. And they earn this in 2 ways. The first way is through an interprofessional community service experience, and shown in a photo here is an example of our culinary medicine learning experience, where medical students and dietetics students come together to offer nutrition programming and actually interact with members of the community who have different health conditions such as diabetes, to help them understand reading nutrition labels and how can they make meals that they enjoy healthier. And they practice cooking together and learning together. And it's really a terrific experience. This digital badge can also be earned through interprofessional simulation experiences. And on this slide are just a few of these types of simulation experiences. So in the simulation center, nursing students and medical students get together in different scenarios around pregnancy and delivery. Our public health students and medical students get together in the county's disaster preparedness simulation that they do, and they work with the county first responders in that simulation. Our pharmacy, nursing, and physical therapy students do a simulation where they use an escape room, which of course is supposed to be very fun, but we've adapted it to a learning experience where they use an escape room to solve puzzles about sepsis and rehab for hip replacement to find the key to get out of the escape room. And that forms teamwork because they have to work together. And then they follow that with a case conference. And then here's an example of physical therapy and occupational therapy working together in a home care simulation for a patient who recently had a stroke. We are so fortunate at UB to have an incredible simulation center. It's now been located in the Jacobs School of Medicine, so our UB Beeling Simulation Center. And I just wanted to show a little bit more about what happens in the simulation center. And so in the simulation center, you're providing your learners with an opportunity to learn in a very realistic environment, high risk, low occurring often, medical and health emergencies, and other things as well. Skills can be learned, and certainly teamwork is one of those big skills. But also, it's a low risk environment for these learners to learn about these very high risk situations. And so part of the realism comes, I don't know if you recognize City Hall in the background of the drape, but we use drapes to help provide that realism. So this is a situation where our mannequin collapsed on the street outside City Hall, and the EMTs were called, and the EMTs are doing their initial assessment and deciding about transportation of this patient. Here's an example of a task trainer. Let me orient you to the task trainer here. So if you imagine someone lying on their back and their neck is towards the medical student and their torso is towards the person who's being trained here, you can see that their neck is at this end, their shoulder would be towards us in the middle, their chest, and then their torso. And the medical student is showing this visitor how ultrasound is used for ultrasound assisted insertion of a central line. So not only can people learn teamwork and skills in a very immersive environment of care, but they also can learn tasks that you don't want to be practicing putting in central lines on people. I know often it's been said, see one, do one, teach one, but now the students go to the simulation center, develop all their skills. And by doing this, there's been national studies that have shown that the incidence of central line infections and pneumothoraces has reduced significantly in the clinical setting in students who have learned how to do this in the simulation center. As well, this is a situation where a child with asthma, which is a mannequin here, has been brought in and the medical student is doing the evaluation. This is a standardized patient portraying the mother. Nursing student is here assisting the medical student. We have vital signs up on the monitor. So again, a very realistic environment for them to learn. A great opportunity to learn those surgical skills Dr. Jacobson was mentioning. So here's a surgical team in the simulation center with a mannequin under the drapes, and behind the drapes is the anesthesia team. And so how, you know, when a surgical emergency occurs, how does the surgical team work together and how do they work together with the anesthesia team? And it gives a great opportunity to develop those teamwork skills. Here's another example of labor and delivery. So we have mannequins that can deliver babies, and there's a motor inside the mannequin, so you can have a rapid delivery or a stalled delivery. And so there's lots of options that can occur. And then there can be problems with the infant. There's different infant mannequins that have different problems that infants experience. There can be one of the common scenarios that's used is a postpartum hemorrhage scenario. So how do the physicians and the nurses work together, the medical students and nursing students work together to provide the best team care for this mother who's hemorrhaging and the baby who requires some care? And then behind the scenes, so this is when you pull that back the drape and see what's happening behind the scenes, is the control room. And here's where the facilitators help guide the simulation that's going on in the actual simulation rooms. And then following that, the facilitator will meet the learners and take them into debriefing. And it's in the debriefing where the learning really occurs. So the facilitator guides the learners through reflective debriefing, and really helps to solidify a deep understanding of things that went well during the simulation and things that need to go differently the next time that they're in that setting. And so finally, our third digital badge is the healthcare practice badge. And this is earned when our students go into their interprofessional clinical experiences, such as their clerkships. And the students are to engage in different types of interprofessional experiences. And these can be in interprofessional rounding or interprofessional team conferences or shadowing a professional so that they learn more about what that professional actually does in their day-to-day practice. Or perhaps engaging in an interprofessional consult. Here's shown a physical therapist and a medical student working together on a consult for someone in rehabilitation, or providing care. We have a number of medical missions at UB that are interprofessional, and so providing, you know, interprofessional care in those such settings as well. And so our students, when they earn the 3 digital badges, they can put them on their resume, their LinkedIn, email, portfolio. And we really hope with our graduates that not only are they going to be exceptional clinicians, but they also have the edge because they have this robust verified knowledge and skills in interprofessional collaborative practice that can be showcased through their digital badge system. So at this point, I'd like to turn it over to Dr. Jessica Kruger, who's going to tell you about one of the clinical experiences that are available to our students.
Thank you so much. I'm really excited to be here today with everyone and share information about a collaborative practice that we're able to offer at UB. And I want to start off with saying we were actually honored through IPEC for an honorable mention award for public health infrastructure for our work at the Lighthouse Clinic, which I'll be highlighting today. So student-run clinics have been around for a while. Actually, most medical schools have a student-run free medical clinic. And this runs a little bit differently than a traditional medical clinic because students are in charge. Students run the day-to-day activities and really just turn to the faculty for guidance and oversight. There's actually a society for student-run clinics, and this is a national organization. I thankfully have the ability to serve on the national board to help guide interprofessional practice in the free clinic world. I'm also one of the co-editors of the Journal for Student-Run Free Clinics, and so we're continuing to increase the scholarship in this area. And the opportunity of students being in a free clinic helps them to take those skills that they learned, not only in the books, right, but in the simulation center, and actually help a community in the process. So Lighthouse Free Clinic was founded in 2001 by some really fantastic medical students. And this clinic has been operating now, it's one of the older medical clinics that we see in the society. We see about 1,000 patients every year at the clinic. And I came on scene in about 2017, and I thankfully had the honor to work with the late Harry Metcalf and also work with Dr. Schwartz at this clinic. And so through this process and through the growth of this clinic, started out with medicine, and then we added other professions, including my discipline of public health, social work, law, dietetics. We even have dentistry, and we have specialty evenings, dermatology and OBGYN. This allows for students to learn from and about each other and to look at a patient in a more holistic perspective. Our clinic's unique because mostly what we're seeing is occupational health. So people are coming to us for work physicals. They're coming to the clinic to get employed, and they need that signature that they're healthy. Now, this provides us a unique opportunity because we don't have to really deal with a lot of these acute issues. We're not seeing many people coming in for health issues that are chronic, but we can really look at where they're at and begin to form a plan to help them continue to be healthy throughout their lives. And so taking kind of a public health perspective in this. At the Lighthouse, our visits look a little bit different than what you typically see in a primary care setting. Once a patient arrives and walks through the door, they're greeted by a team. And that team includes usually a social work student, a public health student, a dietetic student, and a law student. Varies. We try not to overwhelm people with too many students, so sometimes it's just 2 of the 4. And they really sit down with the patient and go through a screening tool. This screening tool looks at some of the social determinants of health that the individual may be experiencing a burden or lack of access to different services. So for example, we screen for food insecurity. We want to know if someone's having challenges accessing food. We want to know if they have a primary care provider. We want to know if they're smoking. We want to also understand if they maybe have any legal issues to where our law students can support them. And some of the issues in which our law colleagues can help is if someone was denied benefits or are in a challenging housing situation. We also screen if someone is up to date on general health procedures such as dental exams or women's health exams. So we collect that information and build trust with that patient and rapport. we then take that information and present it to the medical team. And so this is a unique opportunity for medical students, usually teams of a first or second year student teamed with a third or fourth year student, so that you have some of that advanced knowledge to learn more about their patient. It's so nice when you can see kind of the holistic view of maybe why someone is doing something or why someone isn't doing something. So oftentimes our review goes something like this. You know, you're about to see Mr. Smith, and Mr. Smith is really stressed today. He's really challenged because he lost his job and he's trying to find a new one. And we realize that he doesn't have a primary health care provider, and he just lost his insurance. He's also not up to date on his dental exams, and he's a smoker. At this time, we work to create a plan. And that plan can be bringing in other disciplines. So it's not just having the patient being seen for their physical exam, but pulling in expertise to say, okay, after you see the patient and as you're presenting to your faculty preceptor, how about we bring in social work? And let's also bring in our addiction counseling services, and let's also bring in law to see if we can get them, you know, back on their feet and not having to worry about some of these outside sources. And so as this patient is within our facility, we are able to help them not only medically, but with a lot of those social burdens that they're dealing with. The patient is also seen by the faculty preceptor, so we're making sure it's not just students that are signing off on these forms. So there is a lot of oversight, and that's where the faculty preceptors do a fantastic job at educating the medical students and other team members about how they can all work together to help this individual. When we look at our patients' needs, it's not just primary care and it's not just health insurance. Many want to learn more about a healthy diet. Many have food insecurity issues, legal services, challenges with getting access to dental care, and even we have a high percentage of tobacco users. And so this really highlights the need for that team to really work together on all of these issues. We not only work in the clinic, we try to work outside of the clinic too. It's important to create connections with the community. This picture is actually a mixture of medical students and the East Side Bike Club, where our clinic has been located in the East Side. And so it's important for us to hear from community members and learn about what's happening in the community. So we try to take opportunities to get students into that community to actually get a view of what's happening and listen to the people on the ground. The other picture is a community health fair in which we're involved in of doing some patient education. So the clinic has shifted over the years, traditionally medicine to now interprofessional. And we're able to add more health professions, connect with the community, and really help students understand the importance of getting that holistic view of what patients need. It's always a challenge as we're changing the dynamic to encourage a team approach. And I think this is a cultural change that I continue to see this evolve and change. When I first joined the National Society for Free Clinics, I was the only public health professional. They had no clue what to do with me. And now we're seeing all sorts of professionals, even in folks in acupuncture and some of these other alternative treatments. We are always challenged by challenges that need innovative solutions, right? If we had all the money in the world, maybe we could solve a lot of these challenges, but our clinic runs on a shoestring budget and with volunteer support. And so we are always trying to come up with new ways to push and challenge the current systems to help our students learn more and problem solve some of these really challenging issues, such as a diabetic not having, a patient with diabetes not having access to healthy food. How can we solve that, right? What sort of structure do we need to change in order to get them access? Connecting patients with resources is always a challenge as we have a strained medical system. And we always want to track outcomes to show that what we're doing matters and how we are taking the approach, this team-based approach, and how it results in more positive outcomes for our patients. So change is gradual, and it's important to allow students to learn through discovery, and that's where that student-run free clinic model comes into place. They get to learn the trials and tribulations. We found collaboration is really powerful, and students walk away with such respect for each other and what each other's profession is. And, you know, planning is always key as you're moving these initiatives forward. So thank you very much for your time. And we look forward to any questions anyone has.
Thank you very much to each of you for those wonderful presentations. Truly inspiring and very impressive how far medical education has come through all of those years since I was a medical student in that little clinic that had such a profound effect upon me. And I'll also say that I'm sure others join me in feeling a great sense of pride that our medical school, our health sciences school here at UB have done such a marvelous job in bringing everybody together, much to the credit of Dr. Otake and Dr. Jacobson and Dr. Kruger. Truly wonderful. So with that, we'll entertain questions from those of you who are in the audience. If you would, when you ask your question, please be sure that your microphone is unmuted. And if you wish, you can also use the chat function and record your question there, and we'll be sure to get to it. So are there any questions? Dr.
Michael, I'll start the ball rolling, and I want to first second your statement. This has been an extraordinary presentation, and for me, and I'm sure all the participants, a learning experience of how much is already happening in the various schools, and our own medical school makes us very proud. This is a tough question, and maybe get Dr. Jacobson. To what extent is fee-for-service a barrier in developing these participatory teams?
That's a really good question. There, as you're probably very well aware, that there are other models of healthcare delivery that are being designed and trialed in all kinds of cities in across the country that may actually be more beneficial to promoting this kind of collaborative care. It is quite possible, and I probably don't want to overspeak, you know, from my perspective, that the fee-for-service model will be changing dramatically in years to come to a more value-based model where, you know, we do see it even here in Buffalo with our accountable care organizations, and where you know, systems are being reimbursed for keeping people well, and that, you know, each person who's involved in this healthcare system, each patient, each person, each life actually is, you know, they're kind of given, these organizations are given you guys, there are probably people who can speak much more eloquently about this too, but they're given, you know, resources to cover them over the course of time, and it's up to the institution or the delivery model to be able to keep these people in, well, reduce costs, and do that in a coordinated fashion, rather than the old system of kind of going from one provider to another and being reimbursed for just the services provided. So those models, I think, will promote the cooperation and collaboration amongst professionals, because the goal ultimately is to improve the health of all, you know, of individuals. So it's an interesting question that you ask, and maybe even Dr. Kruger or Dr. Otake may have some more insights or a way to add to that.
Yeah, I mean, I'd be happy just to share that there have been some studies that have shown that when patients are cared for by a team, although initially there's a heavy investment in that, the patients actually have better outcomes, so they have lower healthcare utilization. And so with that investment, this has been seen definitely in the intensive care unit, where they move to actually adding staff like rehabilitation to ICUs, that hospitals have saved millions of dollars because of the improved outcomes of having this very comprehensive team-based approach. And so I think although there's an investment of paying individuals to care for, paying healthcare providers to care for these individuals, because the health outcomes are so much better, the healthcare utilization actually goes down per patient.
I mean, Dr. Katz brought up a really important point, and it is true. And I'm a physician, and I've been doing this for so long, but our model of being reimbursed for visits doesn't always lead to the best outcomes. And so I think the world has been working on the other systems that seem to make more sense. And I have a feeling we will be all changing to different payment models in the future.
Thank you. Are there any other questions from the viewers?
Dr. Noe, we have a question in the chat. Dr. Walensky asks, have you ever included representatives from insurance companies in the team?
So I can tell you, I think I'm unmuted. I can tell you that in our IPE program, that the MBA students at UB that are in the healthcare tract of the MBA participate in our program. And so they answer exactly these questions. And so they look at insurance from both the system level, but also at the individual patient level as well. So we definitely embrace our management colleagues to help. So they're not exactly insurance representatives, but they're certainly more on the business end of healthcare than the provider end. So we're trying to really make those connections.
I have a question. You're doing truly marvelous work in our professional schools. I'm wondering if any of this is translating over to graduate medical education and the post-academic development of individuals in the other health professions. And I ask that because, being somewhat familiar with the literature in this field, I was made aware some time ago that actually in Europe, in some countries, they require medical students and nursing students in their final year of training to run a floor together on the inpatient setting, so that they really get an experience in the crucible, if you will, where they have to put all of this together in a setting where it is obviously extremely meaningful. So have you seen anything here of the carryover of all of this into the hospital setting? And are there any plans to implement these programs at the graduate training level?
Dr. Noe, those are excellent questions. I'll start by saying that our program, we've done a lot, but we're only 4 years old. We went to capacity full scale in fall of 2016. And our current mandate is to ensure that all of our health professions, pre-licensure health professions programs meet their current accreditation requirements for interprofessional education. And so our program, we're definitely building the ship while we're sailing it. And I'm pleased to say that of the 6 health professions programs, including medicine, that have gone up for re-accreditation in that 4-year period that we've been functioning, that all of the programs have, the majority of the programs have exceeded the expectations of the accreditors, and if not exceed, that they definitely met them all. So, but our goal is to move, once we're sure that we've got our pre-licensure mandates completed and in good shape, we would really love to move into graduate medical education. And as well, we're educating these students to go into a system that isn't always collaborative. And
Right.
so we feel a real need to also, as resources permit, to partner with our healthcare providers that we work with to start to collaborate with them to provide this type of education to their current providers, so that our students are actually going into a culture, a local culture of even more collaboration than currently exists.
Thank you. Are there other questions?
Yes, we have a comment from Dr. Rokicka.
I have what I will call a sidebar. I think we just witnessed a trifecta. I mean, this was amazing. Any one of those three presentations that we heard just now was exceptional, really. I thank all three presenters, and I have to thank the Medical Emeritus Faculty Society for having the wisdom to invite these individuals. But my sidebar really includes the following observation. You know, we talk about the mind, body, soul connection of individuals, be they patients or caregivers or healthcare providers. And I just want to add the fact that, and Dr. Otake has been involved in this, campus ministry at the Newman Center has been involved in providing a series of medical ethics conversations that our medical students have been involved in. And quite recently, we actually got on board with the interprofessional education aspect and invited medical students to talk to nursing students and pharmacy students about various medical ethical dilemmas they might encounter in their practices. Dr. Joe Caruana has been really creative in providing animated animations and case studies that form the focus of the considerations that these students are concerned about. And I really encourage the philosophers among us, the faith-based individuals among us, to make sure that our students recognize that not only are we dealing with patients and their medical issues, but as you well know, you've talked about social welfare being involved. We've got to make sure that we look at an entire, whole, complete patient. And I'd like to think that what we're doing in campus ministry is making a difference, particularly for those students and those physicians, by the way, and those pharmacists and those nurses who come and enter into conversations with our students. So the collaboration that we're talking about is not just amongst practicing professionals, but amongst the practicing professionals and would-be practicing professionals. Just a sidebar.
Thanks, Dr. Rokicka. I see we have a question from Dr. Amit Kandal. He thanks each of you for your wonderful presentations, but asks, can we teach students interprofessional education if we don't practice IPE in our daily management of patients? We have to move towards disease-centric practice rather than specialty-based practice. Who would like to respond to him?
Dr. Jacobson, why don't you jump in?
I'll start, but you know, Dr. Kandal is actually a wonderful example of someone who's incorporating interprofessional education into his own neurology clerkship. And he can probably tell you a little bit more about how he does that. There is a bit of a barrier because we're talking to this group now, right? But you can imagine that culture change takes time. So as you know, our students are going into their residencies and the residents go into their practice, and sometimes they are not met with the same philosophies or that we're trying to teach here. And it might take some time for this pipeline of a new way of thinking to kind of feed its way up into the way we run our healthcare systems. But I do believe there is efforts on the other side working on this, you know, actively. And, you know, again, different physician professional groups are also trying to develop models of more collaborative care. So it does take time to change a culture, but we certainly hope our own students will help to contribute to that change. Dr. Kandal, do you want to tell a group a little bit about your neurology clerkship?
Yes, definitely. So in neurology, we are trying to incorporate physical therapy, occupational therapy, and speech therapy along with neurological examination and management. I am struggling to get all the faculty members on board, and I do understand that it will take time. But the other thing is, it will be easier to teach a student if I start to practice in a collaborative way. There are examples. If you look at Roswell, what they do with cancer is extremely collaborative, what MD Anderson does for the cancer. And I do want to do the same thing with the stroke. We have a lot of stroke patient in Western New York, and outcomes are not as good as it could be. And one of the ways to improve the outcome would be if we have a multidisciplinary one-stop care center where all the stroke patient will come one day and get everything they want in one setup, like a Wegmans. Whenever we go to Wegmans, we get everything there. Why can't we do that with our healthcare system? And that's where the student will learn IPE best. But for that, we have to change the whole system and the way we think and we practice. I am trying from my side, but I'm still struggling to get the whole thing kind of organized.
Anyone who knows me knows I'm an eternal optimist on these sort of things. And every year I say, we're going to have more public health professionals in the medical community. But I've actually seen some change. Many of my public health students are actually being placed in internships in primary care settings. And they've been able to help to advocate and orchestrate some of these collaborations and show it from a market perspective in the way that preventative medicine is important for reimbursement, and the public health professionals can have that bird's eye view of how do we begin to create that systems change. So, you know, I'm right there with you. Let's see this change. Let's make it happen. But I think it's starting to really come to fruition.
I applaud the comments of each of you. And getting back to Dr. Rokic's comment about the ethics program, I have attended a number of those and have really found them to be very informative. So I would encourage all of you who are listening, hoping you might be so inclined to watch the postings for these and to attend and participate. I'm sure that you will get a lot out of it.
Thank you for that unsolicited commercial.
Pardon me? It was unsolicited, yes.
Yes.
We have a question from Dr. Walensky. It seems that the days of the private practitioner practicing from a private office are numbered to be replaced by a medical home. Who would like to comment on that one?
I guess I'll start, but other people please chime in. I think what we've already sort of started to address this, and there are many factors I think that will kind of force the system to change somewhat, including just the baseline idea that we need to provide the highest quality of care in a coordinated fashion. And it's really hard to do that when everyone's isolated in their own offices. And being able to work in environments where you can have that Wegmans, you know, where you do have one-stop shopping, where you have everyone, whether it's under a real physical roof or a virtual roof, where it's easy to be able to go from one service to another and get your labs drawn and your x-rays and see that specialist and get that therapy all together. And where there's a system of people talking on the same EMR, right? Boy, I don't know if any of you struggle the way we do about, you know, the various EMRs and trying to get information on our patients. It's so difficult, and costs and the need, you know, will play a factor because it is less expensive to do it this way. You know, it takes care of people, you know, holistically. And I think worrying about and trying to reduce errors, improve safety, improve the quality of the care that we provide, those things are going to probably shape the healthcare, well, they are shaping. We can see it around the world, around the country, shaping the way the healthcare systems are changing.
Thank you. Any comments from our other panelists?
I think change is hard, and to reimagine some of our existing healthcare systems to become, this Nexus or this Wegmans can be tough at first just because we haven't been part of it. But as things change, I think we can think about this as a way to reduce some of the burdens and barriers for our most vulnerable, including those who have challenges with transportation, childcare, or other barriers that they may be facing, to get all this at one time from one location, maybe, or from a group of providers that at least can communicate together and help really support that whole person wellness.
Thank you. Are there any other questions from our audience?
Michael, maybe time.
Len? Thank you. Yes.
Michael, I'm just thinking we are good point to wrap up. I think this has been an extraordinary experience for all of us, and there's the sense of change is being felt. It's almost a visceral feeling that we are at a time of major change. So I have the distinct pleasure of saying, on behalf of the Jacobs School of Medicine and Biomedical Sciences and of the Medical Emeritus Faculty Society, that we thank Dr. Jacobson, Dr. Kruger, Dr. Otake, and Mike Noe for a most extraordinary presentation today. So we will long be remembered, and thank you so much. And it's been videotaped, so it will be available in the future to others. And I think this will be a real resource for the future. So thank each one of you, and thank everyone for attending. I have to say, on behalf of the Emeritus Medical Faculty, that this is one of our roundtable lunches, and we are planning actively, despite the COVID virus, that we will have programs on a virtual basis in 2021. So please stay tuned for additional information. One major program is emerging clearly, and that is Dean Kane, Dean of our medical school in health sciences and the Vice President for Health Sciences, and also who has managed COVID on the campus, will be our speaker in February, somewhere between, we have the prospective dates, they're not quite set yet, they will be soon, and everyone will be notified that Dr. Kane will be probably our next speaker, unless something else emerges before that, but that's probably what it is. So thank you all for attending. We had an extraordinary session today and greatly appreciated, and have a good day and stay safe. Bye-bye.
And you too, Len. Thank you. Bye-bye.
Bye-bye. This was wonderful. And once again, thank you, Jennifer and Tracy. Bye-bye all.
Bye-bye.
Thank you, Dr. Katz. And thank you, everyone. Wonderful program today.